I am Dr. Paul Levine, Assistant Professor at the University of Texas Health Science Center at Houston School of Dentistry. I am also the Course Director for Studies in Dental Sleep Medicine for the pre-doctoral program here. The following online courses were created to facilitate continuing education in sleep-disordered breathing. It is thought that as many as 40 million people in this country suffer from a sleep-breathing disorder. To date, it is estimated that only 15% of those have been diagnosed and treated. I believe that we must expand the awareness and education to the dental community to increase patient awareness of the health dangers of untreated sleep disorders. This first course will discuss the examination and screening process necessary to identify patients with risk factors for obstructive breathing. Risk factors screening and exam for sleep-disordered breathing, obstructive sleep apnea. As a disclosure, I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time, while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At that time, you will receive instructions regarding taking the exam. Section Overview. This section presents information that will allow the dentist to understand the anatomical and physiological risk factors that need to be assessed to properly screen a patient for the presence of obstructive sleep apnea. Questions to ask each patient when sleep apnea is suspected will be discussed. Finally, samples of exam forms specific for sleep apnea will be shown. Section Objectives. Identify the signs and symptoms that would indicate the presence of obstructive sleep apnea. Understand the steps included in a proper exam prior to initiation of oral appliance therapy. Learn various screening tools to use during an exam for obstructive sleep apnea. And know which questions to ask a patient if the dentist suspects obstructive sleep apnea. Risk factors screening and exam for sleep-disordered breathing, obstructive sleep apnea. Before we begin our discussion of risk factors, I want to mention this. Under the category of sleep-disordered breathing, there are several other conditions that mimic or share similar symptoms of obstructive sleep apnea. Some of these include insomnia, periodic limb movements of sleep, upper airway resistance syndrome, narcolepsy, hypoventilation syndrome, and central apneas. But for the purpose of this presentation, we will limit our discussions to obstructive sleep apnea. There are numerous medical conditions associated with sleep apnea. These include heart attack and stroke, insulin-resistant diabetes, other metabolic disorders, hormonal imbalances, cognitive disorders, nocturia, which is excessive nighttime urination, fibromyalgia, GERD, ADHD, and even cancer. I teach an undergrad course here at the dental school in sleep-disordered breathing. I tell my students that when they're reviewing the patient's medical history, if they come across any of these conditions, a light bulb should immediately go off in their head, and they should at least consider the possibility of a sleep-breathing disorder. It is known that the #1 cause of death in this country is cardiac arrest. It is now thought that the #1 cause of cardiac arrest is untreated sleep apnea. The pathophysiology of sleep-disordered breathing seems to have one common denominator, that is, inflammation. It is thought that most chronic diseases are due to some kind of inflammatory response, as this illustration shows. This slide is a little wordy, but it discusses the fact that OSA leads to hypoxic stress. Hypoxic stress is an activator of lipotoxicity and inflammation. During sleep-disordered breathing at night, or when the patient's sleeping, there are rapid swings in deoxygenation, and then there's reoxygenation. These rapid swings lead to lipotoxicity through impaired glucose homeostasis. This lipotoxicity activates pro-inflammatory pathways, which ultimately lead to insulin resistance. So here we find the pathway to diabetes is ultimately due to inflammation. Lipotoxicity also increases the distribution of body fat, which can also lead to inflammation. Our fat is stored in cells called adipocytes. Adipocytes are a major source of circulating cytokines. Cytokines both induce and respond to pro-inflammatory stress pathways. So here is a pathway for increased fat causing inflammation. Next, I will point out one of the cardiac consequences of inflammation. This is in the form of arteriosclerosis. Arteriosclerosis involves chronic inflammation of the vascular wall. Myocardial infarction and stroke are typical manifestations of severe arteriosclerotic disease. Intermittent hypoxia is thought to be the main component linking obstructive sleep apnea to cardiovascular disease. A pivotal mechanism of arteriosclerosis is endothelial dysfunction. Simply put, hypoxia leads to oxidative stress, which leads to inflammation, which leads to arteriosclerosis. Many patients with OSA also have what's known as metabolic syndrome. Metabolic syndrome includes all four of the following: obesity, hyperlipidemia, hypertension, and glucose intolerance. There was a study done in Brazil at the Paulo Medical School. And in that study of their patient pool, 63% of those with metabolic syndrome had obstructive sleep apnea. This chart shows the prevalence of sleep apnea and comorbidities. This is a chart I like to show my patients, and I would encourage you to discuss this with yours. For example, if your patient presents on multiple medications for their hypertension, and you take their blood pressure, and their blood pressure still is not under control, in this study of those patients that had drug-resistant hypertension, 83% of those were shown to have sleep apnea. In this study of the patients that were obese, 77% were shown to have sleep apnea, and so on and so forth. This information can make a profound statement when you're trying to educate your patients on the ill health effects of untreated sleep apnea. Other risk factors: obesity, being male, excessive daytime sleepiness or fatigue, snoring, witnessed apneic episodes, frequent nighttime urination, having a short mandible, having a lower placed hyoid bone, retrognathia, the presence of a large tongue, small arches, and a large tongue and adenoids. The illustration on the left shows normal breathing during sleep where the airway is open. With obstructive sleep apnea, the airway collapses during sleep due to the tongue and the soft palate. If you compare males versus female risk factors for sleep disordered breathing, men are more likely to have OSA than women are. One of the reasons for this is because men have a longer airway. There's more surface area to collapse. Also, there is an increased fat deposition by males in the neck. This leads to compressing the airway and contributing to its collapse during sleep. Let's move on to screening a patient for obstructive breathing. Screening for OSA, screening tools. For screening tools, we have questionnaires, physical findings, and recording of physiological variables. So let's talk about questionnaires first. There are many questionnaires out there that one can use. Just to name a few: the Epworth Sleepiness Scale, the Berlin Questionnaire, the Stop Bang, and the 4-variable. The Epworth Sleepiness Scale. This questionnaire asks the likelihood of dozing off in a particular situation. It might be sitting and reading, watching television, a passenger in a car, or laying down to rest in the afternoon. You simply add up the numbers, and for example, if it's 13 to 16, that would indicate a moderate degree of daytime drowsiness. Now, it is just a drowsiness scale, but the more drowsy you are, the higher the risk of obstructive breathing. The Stop. The STOP questionnaire just asks 4 questions. Do you snore loudly? Do you often feel tired or fatigued? Has anyone observed you stop breathing at night? Or do you have high blood pressure? If you answered yes just to 2 of these, you're ranked at high risk for obstructive sleep apnea. This study showed that if you answered yes to just 2 questions, you're at high risk for OSA. These 2 questions were, do you snore regularly? And do you sometimes gasp for air during sleep? So sometimes just asking a patient 2 questions will put them at high risk for sleep apnea. The Berlin questionnaire has 3 categories: snoring, fatigue, and hypertension. This is the one we use at the University of Texas School of Dentistry. The patient fills out this form. It's just a checkoff list, and at the bottom part of the list it says final result. 2 or more categories indicates a high likelihood of sleep apnea. It doesn't really matter which health questionnaire you use. Just make sure you pick the one that you feel that's the best for your patients, and stick with that one. So what is the rationale for screening every patient for sleep-disordered breathing? Well, look at some statistics. More than 40 million U.S. adults suffer from sleep-disordered breathing. Approximately 85% go undiagnosed. 50% of Americans snore. 20% are thought to have mild to moderate obstructive sleep apnea. To review the physiology of snoring, when we go to sleep at night, the soft palate drops, the tongue falls back, there's partial closure of the upper airway space, then there's vibration of the pharyngeal walls, and hence snoring. Understand that snoring can be a sign of a sleep-breathing disorder, but it can also have its own cardiac consequences. In this study, heavy snoring significantly increased the risk of carotid arteriosclerosis. The actual vibration of snoring causes a disturbance in the endothelium of the carotid artery. This disturbance leads to an inflammatory response, and this inflammatory response leads to the formation of plaque in the carotid artery and hence arteriosclerosis. And this is just from the vibration of snoring. The presence of a swollen uvula may not indicate an upper respiratory infection. This could be a risk factor for sleep-disordered breathing. The vibration of snoring also can cause the uvula to become edematous. So don't let this fool you. Physical findings. We measure the neck and determine the BMI. These can be risk factors for obstructive sleep apnea. With the oral exam, we will look at the skeletal relationships, the arch forms, tongue size and position, or the presence of scalloping. We'll look at the tonsils, the uvula, the soft palate, and the hard palate. We will determine the Mallampati score. We'll look at the nose, and we'll look for the presence of tori. Let's start off with the Mallampati classification. There are 4 classifications, 1 through 4. Number 1, Mallampati 1. The soft palate, uvula, posterior tongue, and tonsillar pillars are all clearly visible. Mallampati class 2. You can see the end of the soft palate, the tonsils and most of the uvula are visible. Mallampati 3. Only the end of the soft palate and the base of the uvula are visible. Mallampati 4. You cannot see the end of the soft palate and the uvula is not visible. So let's move on to these illustrations. If we look at the illustration on the left, Mallampati Class 1, you can see the entire uvula, you can see the end of the soft palate, and the airway is significantly open. Mallampati Class 2, about half the uvula is covered, but you can still see a significant portion of the airway, and you can see the end of the soft palate. Class 3, you really can't make out much of the uvula. It's pretty much covered up. You can just make out the end of the soft palate and see a little bit of the airway, but that's all. Mallampati Class 4, you cannot see the end of the soft palate. You cannot see any other uvula. It is completely covered up. You see no sign of the airway. So here's a Mallampati Class 1. Again, the airway is wide open. You can see the entire uvula. You can see the entire end of the soft palate. This is an example of a Mallampati Class 2. Here's another example of a Mallampati Class 2. Again, about half the uvula is covered, but you can still see the end of the soft palate, and you can still see a fairly significant part of the airway. The Mallampati Class 3, most of the uvula is covered up now, and you can just make out a little bit of the airway. With the Mallampati Class 4, you see no sign of the uvula, no sign of the airway, no sign of the end of the soft palate. When we dentists are doing the Mallampati score, we do not want our patients to stick out their tongue. Sticking out the tongue puts tension on the palaedoglossus muscle. This tends to raise the soft palate and gives us a false sense of the Mallampati score. We do what's called the modified Mallampati. I sit my patients up, I tell them just to relax their tongue, do not stick your tongue out, and I tell them to open their mouth, and I look in and I see what I can see. Again, this is called the modified Mallampati. There are several risk factors in this one slide. This patient has a narrow arch, a large tongue. Notice the tongue is above the occlusal plane, and there's a scallop tongue. These are all risk factors for sleep-disordered breathing. Whether you're examining your pediatric patients or your adult patients, when you see enlarged tonsils like this, please suggest a consult with their ENT. These are considered Class 4 tonsils. These can easily lead to an obstructed airway. Pediatric sleep apnea is very prevalent in this country. So get in a habit of looking at their tonsils on every patient that you screen for sleep-disordered breathing. Anything that reduces the amount of tongue space can contribute to obstructive breathing during sleep. Notice in this slide the presence of large tori. This could keep the tongue in a posterior position, which contributes to obstruction of the airway during sleep. Here again, several risk factors are present. Large tongue. Tongue is above the occlusal plane. There's a scallop tongue, fractured teeth, worn teeth. It only takes a moment to look in a patient's mouth and recognize some of these risk factors for sleep-disordered breathing. What does OSA have to do with bruxism? Well, what we know is when a person goes to sleep, the airway collapses, there's a drop in esophageal pressure, there's an activation of the sympathetic nervous system, then there's an increased effort to breathe. Following that's an activation of the clenching muscles and the tongue to thrust anterior, and then the airway opens. So the question is, why do people brux and clench at night? Well, the answer is it is thought to protect the collapsing airway. Here are two studies that were done that showed a correlation between obstructive sleep apnea and bruxism. However, a direct cause and effect has not been determined yet. More studies are needed. In the most recent International Classification of Sleep Disorders, ICSD-3, bruxism was redefined as a sleep-related movement disorder. But for now, just understand that bruxism is another risk factor for obstructive sleep apnea. Understand that there are limitations to our exam. Our exam is performed while the patient's awake. It is performed at a certain moment in time. But sleep pathology is a dynamic process. Yes, OSA is about anatomy, but it's also about the physiology that's occurring while we're sleeping. It's about the physiology of the changes in muscle tone when we're sleeping, the changes in airflow when we're sleeping, and of course the position our body's in is different when we are sleeping. So please remember that what you see in your exam may be somewhat different than what occurs while sleeping. Another thing to consider is where the obstruction is. When we treat our patients with an oral appliance to help open the airway, we are opening the airway at the level of the velopharynx. As the illustration shows, that is where the tongue and the soft palate come together when we're sleeping to constrict the airway. If the obstruction is further down in the oropharynx or in the hypopharynx, our oral appliances may not work to open the airway. So sometimes it's important to know where the actual constriction is. This is where a cone beam CT scan could be very beneficial. In this illustration here, it shows that the obstruction, or the smallest part of the airway, was at the level of the velopharynx. However, if we treat a patient for sleep apnea with an oral appliance and it's not effective, we have to think that the obstruction may be at another site than the velopharynx. So that may be an indication to send our patients for a cone beam CT scan to see if the obstruction is elsewhere besides the velopharynx. The point is that we can better predict that our oral appliances will have the desired effect to open the airway if the obstruction is at the level of the velopharynx. Let's move on to screening tools. Recording of physiologic variables. For recording of physiologic variables, we have clinical findings, quality of sleep questions, other signs and symptoms. Clinical findings. These are clinical findings that would possibly be predictive of obstructive sleep apnea. These include somnolence, which we call EDS or excessive daytime sleepiness, cognitive impairment, daytime fatigue, waking up with headaches or headaches throughout the day, mood disorders, and sexual impotence. These symptoms may be present in OSA and they may improve with treatment. Associated symptoms of OSA. These can include hypertension or other signs of cardiovascular disease, witnessed apnea, weight and BMI, especially increased weight, an increase in BMI, daytime sleepiness, type 2 diabetes, sleep questionnaires that indicate higher risk for sleep disordered breathing, fatigue and irritable moods, impaired functioning, nocturnal bruxism, and nocturnal GERD. Recording of physiologic variables, quality of sleep questions. These are questions to ask your patient when you're screening them for the possibility of sleep disordered breathing. Do you snore loudly? I like to ask my patients if anyone has ever heard how much you snore, rather than just ask the patient, do you snore? A lot of patients don't know if they snore or not because they're asleep. So that's why I like to ask, has anyone ever heard how much you snore? Has anyone ever heard you stop breathing or have heard pauses in breathing during sleep? Has anyone ever heard you choking in the middle of the night? Do you suffer from acid reflux? Do you toss and turn during sleep? Sometimes it's important to interview the bed partner because this is the only way we may get this type of information. Do you wake up frequently during the night? Or do you wake up to go to the bathroom during the night several times a night? And of course, do you suffer from daytime sleepiness? Additional symptoms of OSA. Awakening with nasal congestion. This is due to the abnormal pressure changes that are going on in the upper airway all night long. A patient may drool on the pillow at night, or they may actually wake up with a dry mouth. Most of this is from mouth breathing, whether it's drooling or waking up with a dry mouth. I find most of my patients will complain of waking up with a dry mouth. So I ask them, do you find yourself waking up with a dry mouth in the morning? This is a sign of mouth breathing, but that's also another risk factor for sleep disordered breathing. Night sweats. Understand that with sleep disordered breathing, there's activation of the sympathetic nervous system all night long. That's why a patient can have night sweats. These are signs and symptoms of obstructive sleep apnea that would require a sleep evaluation. Now, most of these are repetitious, but I think it's worth repeating. Hypertension. Are there signs of cardiovascular disease? Witness apnea. Weight and BMI. Daytime sleepiness. Type 2 diabetes or insulin resistance. An Epworth sleepiness score greater than 8. Fatigue and irritable moods. Frequent arousals or insomnia. Nocturnal bruxism. Loud snoring. Nocturnal GERD, taking sleeping aids. To help facilitate determining efficacy of an oral appliance, we have some general guidelines that we can go by. So, statistically, good responders to our oral appliance therapy will have a neck that is less than 16 inches for a female or less than 17 inches for a male. They will have free nasal breathing. Their BMI will be less than 32, which means they're not obese. They may be a female. They were diagnosed with mild to moderate OSA. And they might have a short lower face, which indicates a less constricted airway. Statistically, poor responders have a neck size that's greater than 16 inches for a female or greater than 17 inches for a male. They might be obese. They might have a class 3 occlusion. They cannot protrude more than 6 to 7 millimeters. They have a very small maxilla, or they were diagnosed with severe obstructive sleep apnea. Let's move on to some talking points. Questions to ask your patients when you're interviewing them for the presence of sleep-disordered breathing. Has your weight changed compared to a year ago? Have you been treated for nasal congestion? Do you move around much at night when you're trying to sleep? Do you have to take alcohol or sedatives to help you sleep? Are you tired or sleepy during the day? What position do you sleep in? Do you sleep on your back? Do you sleep on your side? Are you happy with your sleep? What is the frequency and loudness of your snoring? Have you had sleep studies before? Or have you been treated for snoring previously? Do you ever awaken gasping for air? Have you ever been told that you stop breathing while you sleep? Do you suffer from acid reflux or a bad taste in the morning? Are you unable to control your blood pressure with multiple medications? Are you having trouble controlling your blood sugar? Do you wake up often to go to the bathroom? Do you wake up with headaches? And are you trying to lose weight but you can't? The clinical exam. In the clinical exam, we'll of course look at their teeth, the number of teeth. We want 8 to 10 teeth per arch. Our dental appliances need to snap in and be stable, so that we must have at least 8 teeth per arch. We'll do a periodontal assessment. We want a good stable dentition for these sleep appliances to snap onto. Presence of crowns and bridges. That's not a contraindication for treatment, but we just want to record the presence of crown and bridges. We're going to look at the occlusion. We're going to look at the palatal arching. We're going to look at the range of motion, and of course their protrusion. So the clinical exam itself. The following forms represent the minimum amount of information that should be obtained prior to constructing an oral appliance to treat obstructive sleep apnea. I will briefly review some of the information on these forms. Okay, craniofacial anatomy. I simply look at the patient's profile. A retreated chin could indicate a smaller airway. Nose. We humans are obligate nasal breathers. We want our patients to breathe through their nose at night while sleeping. If not, I'll refer them to their ENT. Dentition exam. Part of that is signs of clinching and bruxing. We look for abfractions, wear facets, linea alba, fractured teeth, scalloped tongue. Here we see a scalloped tongue and fractured teeth. These need to be recorded. We look at the arches, see if the arches are crowded or not. Crowded arches can indicate a smaller airway. Occlusion. We record, is it a class 1, class 2, or class 3? Is there an open bite? Is there an anterior open bite? Or is there a posterior open bite? And the periodontal condition, just the status of the periodontium. Again, we want a good, healthy periodontium to have a stable base for our oral appliances to be seated on. Soft tissue. We look for the presence of linea alba. We're going to look at the tongue, the uvula. We'll get a Mallampati score, and we'll look at the tonsils. Remember I talked about how snoring can cause what looks like a swollen uvula. It becomes edematous. We check off if the uvula is normal, elongated, or edematous. Enlarged tonsils. Class 1, Class 2, Class 3, Class 4 tonsils. Of course, these are Class 4 tonsils, so we record that. Arches. We record if the arches are normal or narrow. The palate is vaulted or normal. Understand that a person with a narrow arch usually has a high vault. The roof of the maxilla is also the floor of the nasal passageway. So the higher the vault, the more constricted the nasal airway can be, and this can be a risk factor for sleep-disordered breathing. Narrow arch width. Here we see, besides a narrow arch width, the tongue is above the occlusal plane, and there's a scalloped tongue. All risk factors. Muscle evaluation. We palpate the muscles of mastication. We're just looking for any sign of soreness. We'll palpate the temporalis, the masseter, the medial pterygoid, the temporalis tendon, which I call the deep temporalis, and the anterior and posterior digastric muscles. The masseter. We do an external and bidigital palpation of the masseter muscle. The anterior temporalis. The digastric muscles, the posterior and anterior digastric muscles. The medial pterygoid. And the temporalis tendon. Note I said the temporalis tendon. When we palpate the temporalis muscle, as shown here, our fingers are actually palpating the temporalis tendon. However, if the temporalis muscle is sore, it's going to show up as soreness in the temporalis tendon. We check the temporomandibular joint for any soreness with the mouth closed. And we check the TMJ with the mouth open. We check the joint for any signs of clicking or popping or crepitus, and we record that. Mandibular range of motion. We want our patients to be able to open at least 40 millimeters or more to say that they are a candidate for oral appliance therapy. We want them to be able to move right and left lateral 7 millimeters or more, and we want them to be able to protrude their mandible 7 millimeters or more. So I simply take a millimeter ruler, ask the patient to open as wide as they can, and I measure. And if it's 40 millimeters or more, that is what I want to see for them to be a candidate for oral appliance therapy. I check to make sure that the patient can protrude at least 7 millimeters or more. Since the premise of our oral appliance therapy is to protrude the mandible and open the airway, if a patient cannot protrude enough, then our oral appliance therapy is not going to be effective. So just understand they need to protrude at least 7 millimeters, hopefully more. I check lateral movements. Hopefully that's 7 millimeters or more, right and left lateral. The midline. Many patients, when they open or protrude, their mandible will deviate to the left or to the right. Now that is okay. There's nothing wrong with that. But if you take your impressions and take your protrusive bite record and send this to the laboratory, and the laboratory does not know that your patient's natural, that they have a natural deviation to the left or to the right when they open or protrude, they will send your case back and tell you that your bite record was taken in the wrong position, that the patient has deviated to the left or to the right. So if you notice that when the patient opens and protrudes and there is a natural deviation, just write that on the lab slip. That's fine. There's nothing wrong with that. Just note that. So check for any deviation on opening and in protrusion. Dr. Michael Simmons is a nationally known educator in dental sleep medicine. He said, "We as dentists can make an enormous difference in society and serve the public in a meaningful way by catching sleep-disordered breathing early on in the continuum and co-treating with our physician colleagues. We can save more than a tooth, maybe a marriage, by addressing the snoring, and maybe even a life." Need clarification? Send an email to utsdcontinuinged@uth.tmc.edu. Here are references listed. This completes the section on risk factors, screening, and exams for sleep-disordered breathing, obstructive sleep apnea. It is time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 90% is necessary in order for you to advance to the next section. Upon a successful completion at this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you will be instructed to take the exam and a new set of questions will be provided. You will have 3 chances to fulfill the requirements. If you are not successful, you will be instructed to review this section again. Good luck on the exam.